Good afternoon, and welcome to the Key to HIE Sustainability Population Health, a complimentary webinar from healthsystemcio.com. Little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I'll be your moderator today. We encourage you to ask questions. You can type them in at any time in the Q&A box in the lower right-hand corner of your screen. Go ahead and send those in. Leave the default set to all panelists, and we'll be taking them later in the program, but you can go ahead and send them in as they occur to you. You can download the deck using the URL on your screen, and I'll send it out in the chat box. Also, there's a shortened version at the bottom of each slide. And we are recording today's event, so we will have an archive available within 2 business days, if not sooner. You'll get an email when that's available, and a separate registration is required. We're going to go about 40 minutes today. First, we're going to hear from Jonathan Goldberg, VP of IT and CIO at St. Peter's Health Partners. And then we're going to do our Q&A with Jonathan. So without further delay, I'm going to turn it over to our friend Jonathan Goldberg. Jonathan, thanks for joining us.
Thanks, Anthony. I appreciate it. And of course, I appreciate the fact that I can step away from talking about population health daily to doing this and talking about population health. So it was a nice departure and a break. So I thought I would just talk the normal overview of the organization, and I'll speak quickly around this. You can see on the slide what makes up St. Peter's Health Partners. I think the uniqueness that we have, aside from having a pretty significant organization around acute care with a little over 1,000 beds, about 30% of our business is actually in the continuing care market, and that includes nursing homes, assisted living. We have one of the largest hospice organizations in the country, serving about 600 patients a day. So, you know, one of the things as we look at our strategy, and we'll talk about in a little bit, is we are definitively really, because of the breadth of services, population health is critical to us because we basically serve that, you know, cradle to death type scenario that people talk about. So if we can control it, we can manage it, we think there's a lot of opportunity. And certainly St. Peter's Health Partners was built through a merger of 3 other health systems that came together about 3.5 years ago for the sole purpose of looking at how we can reform healthcare in this region and how population health would be kind of the center of that. The next slide is really just of our location. We cover about 7 counties in upstate New York. With that, probably most of our locations are all centered in about a 30-mile radius. From north to south, we cover about 100 miles. But again, while we're continuing to probably grow in all directions, and we will continue to see that, whether it be through affiliations or direct acquisition, we're still kind of at least really centered in the capital region within Albany, New York. So one of the things I thought, before we talk about the public HIE, I thought it would be worth mentioning that we do have a private HIE within St. Peter's Health Partners, and that private HIE is important to our strategy, as I mentioned, because of our breadth of services and us wanting to really try to tie together such a disparate organization. Right now we have 20-plus EMRs that span, and you know, some of them are niche EMRs that cover we have an addiction services division, as well as we have EMRs in all of our nursing homes, and we're even going to do something with our assisted living, which typically you don't see EMRs in, but we felt it important to be able to understand that what's happening even in that arena, even if it's minimal data. So we did put in a private HIE. We are working on that now. We're not fully deployed yet because of the number of EMRs and other challenges, and as well as other priorities. It's been somewhat of a slow rollout with our acute care and ambulatory being the first focus. It serves as our meaningful use portal, so we felt that if we could aggregate instead of having multiple portals to achieve meaningful use in our organization, this rolls it up and consolidates it to one. And it also gives us some of the analytical capability. It can do push and pull of data, so we can create queries to create alerts for clinical data and push those out to physicians that want to monitor specific data sets or, whether it be kind of the typical diabetes or other chronic disease, we can create some of that monitoring. And our goal ultimately is to sort of funnel, at least for the time being, is to funnel all of our data through the private HIE and certainly then move it out. So kind of multiple pipes into one location, and then we can actually then send pipes out to whether it be the public HIE and some of our other population health initiatives that we're working on, those systems. So, if we can kind of organize the how we funnel information, we think that certainly will benefit us in the long run. So I want to talk a little about HIEs is our health information exchange, and it began in 2005. This is just about the time that MySpace, as you can see, was the big social media darling. So hopefully, luckily, it wasn't foreshadowing of what would be happening with HIEs. I think, as MySpace didn't survive, HIEs certainly has thrived and grown. And I should tell you, in terms of just from a disclaimer, I am a founder and board member of HIEs and HIEs is a vendor to St. Peter's. So so I wear a couple different hats, and then certainly we'll try to balance my my thoughts as we go forward. But certainly I've been involved with HIEs since its beginning about a decade ago. So HIEs formed, it started as an organization, and it was just, that really had a few people at the table talking to our largest payer in the region, and the largest payer said, hey, we have this claims database. We'd love to be able to provide that data to the EDs and to your physician offices so that, we think that could help you in relation to our patient care and ultimately benefiting the payer. And ourselves. And certainly we started those conversations. It didn't get too far because just at that point in time, New York State came out with what they're called the Heal New York grants, and the first round of grants gave $53 million to regional health information exchanges to stand up. And so at that point, we had a lot of participants coming into the fold. We had probably about 20 organizations represented in the early stages to talk about how can we do this, how can we actually create an exchange, and what would it look like. The good news is as part of the HIPAA transactions, we were able to leverage. There was an organization that was already created specifically to help potentially process EDI transactions in upstate New York. That never really took hold as part of HIPAA, so at least in this region it didn't. So but it was already organized and it was already a formal corporation, and it was called Health Information Exchange of New York. And so we actually absorbed that organization, and it became sort of the holding for our Health Information Exchange. So it kind of fell into place pretty well. So early days too, I was trying to prepare for this, and I was looking through some of my old emails, and before I had to purge them shortly, and I was looking at the first letter we sent HIEs in terms of our participation in HIEs, and you certainly can see how much we were looking this was specifically only St. Peter's Hospital, the financial support. But what was kind of interesting, and I highlighted the fact that and we held HIEs to a lot of different criteria as I looked at the 5 or 6 different things that we said that were contingent upon our funding. And one of them was just protection against competitors using this as an advantage. So you could see that there was certainly a level of distrust and a level of anxiety about what would this mean to the region, and where does each healthcare organization stand. And what's interesting is that's starting to show, and the same premise really is when I talked about foreshadowing earlier. This is population health all over again in relation to us now working with other partners and having to share data on a population among people who normally we compete with on a day-to-day basis. So I'll talk a little bit about that, this region, what's happening, but certainly that's what we overcame in 2005 through 2007. It looks like we're going to be doing all over again for 2015 to 2017. So just thought that was kind of interesting. So I also found in my files one of the first income statements for HIEs back in 2006, and they were I wouldn't consider them a wealthy organization. They showed a total income of just shy of $150,000. So, and I'm not even sure where they got that. It could have been just a couple bake sales that they held, or maybe they were standing in front of the supermarket with cans. But they certainly did have at least an early beginnings, and they certainly have grown quite a bit since then. So I took a couple slides from the slide decks that they provided to me, and you can see within New York State, which is the total slide, you can see the purple is the region that HIEs covers, about a third of New York State counties, which is about 1.6 million residents. And I think HIEs likes to say that it's larger. That itself is larger than 12 states. You can see the sort of where they're connected to with the little purple dots, and of course the size of the dot equates to how many connections that they're or lives that they're covering. Have a lot of EMR connectivity, and certainly are building out, where they saw the roots was connectivity, sharing data. Certainly are building out beyond that at this point. So when we talked about, they talk about connectivity and a leader in the HIE space, right now there's about 72% of primary care physicians are connected, and when you aggregate the specialists, you're about 70% penetration of physicians in that region. And 95% of patients give consent. New York State's an opt-in state, so we're having good success at having a very robust data set of data available to us because of that consent rate. You can see the number of connected healthcare locations. All hospitals in the catch basin are connected, including some public health organizations, and three of the major health plans are also connected to us. And we also have paying membership from education, consumer, and in the public space, and some associations in the region are also participating. So it's interesting to see them come to the table because they feel that this is an important organization to be part of in terms of the future of the area and what it can provide. You can see some of the statistics. I won't read them, but certainly the one at the bottom is the one that always catches me. It's that 175 billion clinical messages annually are being processed through HIEs. So it's mature, it's been very successful, and it certainly the penetration level is significant. So I talked a little bit about population health in our region, and it gets kind of complicated. St. Peter's Health Partners, you can see, is in the center. There's another major health system in the area, it's Ellis Medicine. We partnered with them and created a joint venture which is our clinically integrated network. Specifically right now, that ACO is covering the Medicare through Medicare Shared Savings. We are fully operational at this point with them. It's stood up, it's incorporated, it's participating as of January 1st. Again, that's a 50-50 ownership model. At the top, you'll see Alliance for Better Healthcare is another corporation that's been formed in the region. It's more of a collaborative for the DSRIP program in New York State, and that's the Medicaid population. We are participating as well in that. And of course, there's other hospitals and physicians that are participating. The interesting thing is you're now also seeing, as part of Medicaid, the community benefit organizations are also participating, whether these be churches, wellness centers, or soup kitchens, things like that, where they've never specifically have had to participate, and they certainly don't have electronic medical records, but our ability to have surveillance over that patient population and their movement in and out and of those support structures is going to be critical. And so one of the things we're starting to think about is, well, how do we do that? How do we enable us to gather that type of data, and are there tool sets that we can give these community benefit organizations to leverage and monitor that population as they come and go within those organizations. So, and so we anticipate that HICSI, as you see, this is sort of going to wrap around and is going to play in all of these and support us in different ways. And the model of how we're going to do that is something that we're very significantly involved in right now, because certainly we anticipate that because of the amount of data that HICSI has available, and a lot of it is our data, because basically all of the organizations, aside from those who don't have EMRs, are connected to HICSI at this point, aside from maybe a handful of small players. So we certainly have gone into population health in full force here in the region. It's one of our major initiatives at this point. It involves we're about 150,000 lives just between Medicaid and Medicare at this point. So we've got a lot riding on it. We have a lot of people involved in it daily, and certainly we're in constant engagement with HICSI on how they're going to support us. So, of course, sustainability is within the title of the slide deck, and certainly want to make sure we touch upon that and what it means. And so, kind of, we weave the story about HICSI and population health and what it means and where it's going. So, in terms of sustainability, from 2005 to 2010, I mentioned, there was Heal New York grant money. We had assessments that both the payers and providers were paying, the payers and hospitals certainly paying their fair share. And then there was some smaller fees, as I mentioned earlier, about the physician and business class. From 2010 to 2014, the grant money went away. Obviously, the HICSI was continuing to grow, so their budgets continued to grow. The payers basically came forward and said, well, we'll pick up a decent amount of the monthly or the annual cost of the systems and the operating expense of HICSI if you give us access to some of this data for us to utilize and to dig into and be able to analyze. So we felt that, I guess we felt it was a good enough deal to take on. It helped. It really did help with that at that point in time with sustainability. The provider, all the hospitals still continued to pay their share. That really didn't change much. So the payers saw the value in HICSI, the value of the data, and the value to them, and certainly we're trying to promote that and have done so and have been consistent doing so since the early days. In 2014, there was a shift where New York State said that they passed legislation that enabled some funding of the RIOs, and so we actually have significant funding coming through to HICSI from the state. The membership is still paying some dollars. Certainly, it's been decreased, but at the same time, we know that the state funding could go away at any time as they're looking for that sustainability to occur as well. And they're thinking that population health certainly will be one of the drivers that potentially helps prop up the HIEs as they participate in these initiatives and provide value-add service that are getting paid for. The state can then begin to step away from having to prop up the exchanges through. And some exchanges throughout New York State, everyone's different. Some aren't as successful as HICSI's been. Some aren't being as funded as well as, and doesn't have the participation, the membership funding. So we're pretty fortunate here to have support across the board. So, but then comes this year and beyond, and we're thinking, okay, well, the state funding is definitely not guaranteed. We weren't even sure if it was going to get past this current year. So we have to go somewhere, and membership can continue to pay, but at the same time, as the industry starts to consolidate, as providers start to consolidate, payers start to consolidate, HICSI's not going to be guaranteed a funding source as it has for the first decade. So we needed to begin to look elsewhere to see where the opportunities may exist. So HICSI started to look at that, the board started looking at it, there were work groups formed, and certainly the question of how can we continue to do what we continue to do best. And certainly where it started, and you could probably go, if you look at this cloud diagram, it goes traditionally left to right. The Health Information Exchange, HICSI's got that down pat, and certainly we have the connectivity, we have the participation. The Health Hub is a solution that HICSI developed in partnership with another vendor to basically support all EMR connectivity in a way that doesn't require a lot of interchange of swapping of specs between vendors. It's agnostic to pretty much any standard and will use any standard. And so as systems change and evolve, it doesn't require retesting. It pretty much takes data and transforms it, I guess, into what HIEs needs to digest it. This has been very interesting to many in relation to potential opportunities, which I'll talk about in a little bit. And then the next slide, which you see we're sort of kind of moving towards and have built some of this out and some of it's still to be built, is really more of the population health tool set. So we have the data, we have the participation, we have all the connectivity. So the next question is how do we use all that data to support population health? And the question right now is there are tool sets that are very valuable to providers, whether it be secure messaging, there's a mobile application that's been developed, and some clinical dashboards to enable surveillance. There's a very popular service around alerting that people are utilizing to get clinical alerts on patients as they, specifically as physicians can monitor patients as they enter the ED, they can get alerted that's occurred. So there's some real value to some of the tools that are being developed to kind of layer on top of what HIEs already built. And obviously, as we look at population health, the question of where HIEs will provide those services to us as now putting my St. Peter's hat on, will they supply those services to St. Peter's and these joint venture population health initiatives and collaboratives? We certainly anticipate there'll be a lot of value-add services that they do provide, and those will be obviously at an additional cost that will bear as a vendor. So, as part of this discussion about sustainability, we wanted to take advantage of this healthcare cloud and understand, well, where are we going? And as people started to look at HIEs and the success that they've had, both whether it was the state of New York or other exchanges, both in the region as well as throughout the country, there's been a lot of inquiries about whether or not people could leverage what HIEs built. So to kind of leverage and utilize that, we as HIEs created what we call NewCo, and I think there's XchangeWorx seems to be the name that may have bubbled up as the official corporation. But HIEs itself, as mentioned, is a nonprofit organization. It's a collaborative in the community. They are going to create a for-profit entity, which is a subsidiary of HIEs, and it'll be a separate organization that has a for-profit that would allow HIEs to sell services outside of their core region and core competency here and leverage what's been built. So there's been a lot of interest in some of the opportunities around Health Hub, which I mentioned earlier. There's some exchanges have been interested in trying to basically leverage HIEs in its entirety and say whether they could use that whole technology as their exchange in other areas of the country. And certainly as the health cloud gets built, we can leverage pieces and parts of that. There's a lot of skilled staff that HIEs has that, by creating a for-profit entity, we'll be able to retain those, give them incentive plans that you can't right now through a state-funded organization, and also allow them to create retention programs and other creative ways of just bringing on the type of resource that you need to develop this type of technology. So we think certainly it'll be something that will help us kind of grow into the future. As I mentioned, the other HIEs, there's already a pipeline of folks that are interested that we're talking to. There's ACOs, specifically in the region, that are very interested in continuing to build upon the services that HIEs has now, as well as other services. And there's a lot of different proposals on the table to do some things that take advantage of that. And then certainly from the standpoint of employment, based on the pro forma that we have, if some of the business comes as we anticipate, there's a creation of over 40 jobs over the next 3 years in the region. So you could see benefiting not only healthcare organizations, but supporting the community as a whole in job creation. And so I have the slide, as Hugh McLeod from Gaping Void says, how to achieve greatness, do something great. I think there's the anticipation that this is at least an attempt at doing something great. Hopefully this does come together as anticipated, and then at least if for some reason it doesn't, then at least we can't say we didn't give it a try. So that's all I had for today. Hopefully it was useful, and certainly open to any questions if any.
Very good. Well, thank you so much for that presentation, Jonathan. And now we'll do our Q&A. As I mentioned, go ahead and send your questions in the Q&A box. Leave the default set to all panelists, and I will pose those to Jonathan. So first question, Jonathan, can you expand briefly on the opt-in patient consent process being used?
Sure. I mean, New York State's been an opt-in state for quite a while, and so the register, if I'm understanding the question correct, I mean, the process we use here is the state's very prescriptive about the forms you use, so they provide those. We collect them at registration, so we're asking the questions, at the registration point of whether or not you want to participate in HICSNY. We explain what it is. We have brochures available. We've trained the registration staff, and I'm assuming all organizations have, to be able to support that. And so most patients are very willing to do that. They see the benefit. There's certainly in certain pockets there's patient portal available as part of being able to opt in and see that data, and hearing some of the stories that have come from having participated. There's been some press on it. So there's certainly a lot of value to participation, and we've been able to really see that occur through again, and I think most people are comfortable with HICSNY now. It's been such a mature model, and we don't see that changing. I mean, there's been questions for quite a while whether New York State would loosen up that requirement, but they haven't to date. Anything subject to change, of course.
A similar question, just let me know if you've covered this or want to add anything. Please talk about consent management. Any thoughts of opt-out consent models?
Yeah, well, from the standpoint of opt-out, I mean, that's for New York State. New York State hasn't, as I mentioned, it has been an opt-in for the last decade. I don't know if they're planning on changing that at this point. In terms of the consent management, there are some pieces to that which I should have mentioned earlier. When we collect these consents, we do store them, we scan them, and there's a flag in our system that identifies whether there was a consent. That gets transferred to HICSNY for consent management. So HICSNY is looking for that yes/no flag. And that gets updated each time a registration occurs. And New York State requires ongoing audits of consents, and so HICSNY is responsible for auditing each of their providers that are members for those consents, and we do that on an ongoing basis.
Okay, very good. Question, you talked about the concern you had with sharing data with competitors back when HICSNY was first starting. Are you still seeing that hesitation when it comes to building population health models?
Yes, very much so. Now, HICSNY we've overcome. I mean, at this point, everybody's a member of HICSNY. We're participating. There's been, and keep in mind, though, HICSNY doesn't, no member right now, we have no aggregate ability to report out of HICSNY as an organization. I mean, HICSNY obviously can get access to their own data, but we don't. So one of the things that is a little different with population health we're finding is that certainly, whether it be access to claims data or access to clinical feeds, these collaboratives require a level of trust because there is more aggregation of data coming out or potentially coming out to membership. And there's still quite a bit of skittishness, especially from the physician population, as to where their data is going. And so, is Big Bad St. Peter's, for example, going to use our data to look at, competitiveness and where where they may be able to do things, since now they have access as part of population health initiatives that we're participating in. So, it's the same exact thing that I pointed out in 2007 with HIEs about using things as a competitive advantage. I think there is still that sense of data governance issues with where the data is, who's using it, and are the big healthcare organizations and/or payers, for example, using the data, or will they use it for data for other purposes? And I think that's something we're going to have to overcome. And certainly, I haven't figured out yet how to do that. I've mentioned it in a lot of venues around having to build that level of trust. So I guess just maybe time will solve that.
A couple of questions about Health Hub. What is your governance model for Health Hub? Have you run into any issues using that type of model?
Well, the Health Hub is really the connectivity between EMRs and HIEs to allow HIEs. It's a tool that allows HIEs to connect to EMRs in a lot easier fashion to manage that. And it's something that makes it a lot easier. The reason why HIEs penetration was so great in connecting to EMRs was because of this tool set. So there's no real governance per se issue of Health Hub, but there is. It's not the data itself. It's just a connectivity tool.
Is it cloud-based? I don't think so. Now, I don't run the Health Hub, the technology, but I'm pretty sure it's hosted out of the HIEs data center. So I guess if it was provided, as I was mentioning earlier, there is a business being developed around providing that service. So it would be cloud-based to other HIEs or other healthcare organizations that would want to provide it. Us locally here as part of HIEs, it would not be considered cloud-based. We're talking about sustainability, and you mentioned the idea that I think you were talking about the payers, giving the payers access to the data. They were willing to pay for that. It helped with sustainability. Is that just an inevitable part of making these sustainable? There's value in that data, and then so selling that in a sense in an appropriate manner, is that a critical ingredient for sustainability with HIEs?
That's an interesting question. I mean, certainly the payer market here is unique, a little unique, because we don't have a large concentration of large national payers. We have a couple local payers here that have a significant market share, and they're local to our market. They're nonprofit pay. One of them's a nonprofit payer, physician governed. They were the ones that certainly they're very focused on our community and our community only. One of the things we found with other HIEs is if you're in a place that's an Aetna or an Anthem, for example, they can't participate in every HIE that they're in a market, because certainly they're in every market just about. We've been fortunate enough that we've been able to have close relationships with the payer. So. And they've been a very significant player in our HIE in HIEs as part of the ongoing sustainability. So I don't think it's necessary, but I can see that we've been, I think, a little bit lucky in a sense to be able to have them participating.
Very good. Are there any research-oriented solutions that HIE data is being used for, and how is patient consent being managed for research? Any thoughts there?
Yeah, that's come up before, and there's a lot of organizations, there's a lot of universities in our region that have talked to HIEs about wanting to access that data. As long as and New York State has some, and I'm not familiar with all the regulatory pieces around the research, but New York State has put some parameters around how data can be used from the exchange, and I'm pretty sure there's some ability to use it as long as it's in a certain de-identified way, and obviously not marketing purposes, et cetera. But I know there are some rules. I can't speak to all of them, but I know there's interest.
Very good. Next question. Is there a data governance structure, and if so, how is it operationalized? Yeah,
there's certainly HIEs governed under, I mean, the HIEs governance is certainly, there's a board of directors and there's committees that make up that board of directors, under the board of directors. There's a clinical committee, and I think that and the legal committee manage some of the data governance and where applicable. And then, of course, as I mentioned, even on the research, New York State has been pretty upfront about how data can't be used and very prescriptive. So and because no organization other than HIEs can get aggregated data, and this is just, you know, you can only view one patient at a time. Data governance has been pretty, I guess, it hasn't been too controversial at this point because data is not really in any aggregate form going outside the organization, which was sort of back in the early days was something that everybody was nervous about, which was, like we mentioned, around population health. Are people going to have access to these massive data sets that are available in the community and do things with them that may benefit somebody, an organization, and not another? And we haven't found that to be the case.
Very good. Interestingly, you know, HIEs been around for a long time, but, you know, you mentioned that you still need to be thinking about sustainability. It's not solved per se. It's something that you need to continually be creative about. I just want to, if you can address that a little bit. Maybe that's just a reality of these entities.
Yeah, well, I mean, I think it would be no different in the business world. I mentioned, you know, early on, I mentioned MySpace. I mean, we know where MySpace is today. You know, you know, we've sat through many presentations talking about the blockbusters and the taxi cabs and all the industries that didn't keep up with the requirements and the needs of the environment. I think health information exchanges are a little different, but at the same time, I think the premise holds true in that, you know, as the healthcare environment evolves, I mean, a couple of years ago, we weren't having conversations around population health like we are today, as intense as we are having today, and those needs. And certainly the state, you know, didn't fund. Now they're funding. They may not fund again. Maybe the local payer here may be part of Anthem at some point, and funding will dry up. I mean, all those things that have significant change in our environment to drive, and those who are really the foundation of HIEs sustaining. If those go away, I mean, you got to find something to come back in and fund that, and so since there's been no committed funding other than at this point, other than the membership, and if membership changes, that can go away. So I think this new model that HIEs is pursuing of trying to create a business, leveraging, you know, the 10 years of what they've built, I think is our best chance at creating a more sustainable model, which ultimately is more consistent. If it's successful, and as we expect it will be, then obviously at that point it creates a revenue stream that's not dependent on the rest of the environment to any certain degree. I mean, certainly you still have to keep an eye on, you know, if your customers are still in business who are paying you, then the business will be able to still generate the revenue it needs.
Just as a final question, in order for these HIEs to have any chance, the health systems in the area have to embrace them or lead them. If to whatever greater degree you do that and you embrace the HIE and find uses for it and almost make it a part of your operations and use it as a backbone for different types of exchanges, what kind of position you put yourself in if that then goes away? And how do you guard yourself against that? So, for example, like what would happen if HIEs went away? And is that something you think about and are concerned about? And just what are your thoughts around that?
Yeah, that's a very timely question, because and that's a great one, because certainly if that's the final question, I mean, it's something that we've been talking about and thinking about for quite a while, because as I mentioned, not only am I a board member of HIEs and a CIO at St. Peter's, but HIEs is certainly a vendor to us. And the reality is that's something that we do have to consider as we go into developing our ACO and our multiple ACO initiatives, I should say. the requirement for having technology that helps us run our business day to day, and now you're introducing basically community-based organization collaborative to help intersect itself. There's certainly a level of risk there, and we have to. You have to understand what the level of confidence is that HIEs will be here for the long term, and whether or not how far do they entrench themselves in your day-to-day business, and that's something we are talking to HIEs about. We're certainly very transparent about what we're doing, and we're trying, and among ourselves, we're trying to figure out, how far does that reach go, and what redundancy do we may need to build in, so if there was ever an issue where HIEs went away, that we would be able to continue to work. So a very important one. Obviously private HIEs may play into that a little bit with regards to being able to do some of the things we need to do. But we're certainly, it's a little bit of the Wild West right now. We're trying to put all the pieces of the puzzle together, but we're paying attention to that topic very much so.
Excellent. Well, that's about all we had time for today. I want to thank our speaker, Jonathan Goldberg, for giving an excellent presentation, a lot of good information. As I mentioned, you'll receive an email when our archive is ready, and separate registration is required. If you have the CHIME CIO certification, attending our webinars gets you 1 CEU for each event, so go ahead and let CHIME know. And if you've asked us to let CHIME know, we will. Questions, comments, you can email me, and you can go to our website to see our last 12 months of archives and our upcoming schedule. So once again, I want to thank Jonathan, I want to thank our attendees, and everybody have a wonderful day. Thank you.